Kia ora everyone and welcome to our Goodfellow webinar on lower back pain management. My name is Dr. Courtney White and tonight I'm talking to Honorary Associate Professor Giresh Kanji, a musculoskeletal pain specialist and researcher, the chairperson of the New Zealand Pain Foundation and co-producer of the app Pain Guru. I'll now hand over to Giresh. Thank you.
Thank you, Courtney, and thanks for the Goodfellow Unit for allowing me to have this presentation. I will just share my screen now. So one of the main things I want to impart tonight is that quite often in all walks of life, we try and have a single sort of problem and a single solution, and we tend to have this singular thinking, which often doesn't serve us well in a complex world. And this could be economics, it could be anything. And it's the same with low back pain. And only over the last year, I've really started to understand that low back pain is, in fact, not as simple as even I would have thought a decade ago, and certainly even a year ago. And quite often, it's the people that don't get better you really learn from. And that's what I've been sort of doing for probably 20 years now. One of the things I'm interested in is education, and pretty much New Zealand and global as well. And I have collaborated with Professor Partha Rupert at Auckland and Vinnie Lohan, who's an engineer. And we've created an app called Pain Guru. This one is for low lumbosacral pain. And it's for patients, and health professionals can have a look at it. And it's really trying to educate people on what might be wrong, on radiology, what may show up what's wrong, and management. How do I reduce the pain, if possible, from source? The other interest I have is I don't have an interest in patients' pain for weeks or months. You know, if they're coming to me and they're 50, my suspicion is people may live to 100 unless they die of cancer nowadays with all the new treatments we have for diabetes and cholesterol-lowering medications. And really, we want to manage someone's pain for the rest of their life. And I see a lot of 20 and 30-year-olds, and they've got disc prolapses and problems. Now, that disc height and function for them often has to last 70 years. And that's where it's more going to be habits for life that are going to be of use rather than quick fixes and other things. For some people, however, we're sort of in the palliative care, for want of a better word, where their pain is bad and there's nothing we can really do about it except give them medications. And then we see a bit of that as well. I have a very acute and personal interest in spinal pain, besides having managed and treated it for the best part of 2 or 3 decades. In 2012, I was leg pressing at the gym, and I was reasonably fit. I used to play hockey, used to run, kayak, cycle, did Lake Taupo, used to own 2 kayaks in Seatoon, and used to go kayaking most days. And I was at the gym leg pressing 200 kilograms. And some might call that a bit stupid. And as I was doing it, the lever at the bottom slipped and the thing went down on me and crushed my back. I sort of managed to get off the machine and lay on the ground for what seemed like forever. I was in quite severe pain in my back and down my legs. It was quite an intense experience. I did manage to get up and go to the car and go home. And that started a journey of 2 years where I'd be waking every day at 2 a.m. In severe pain, and I wouldn't actually be able to get back to sleep. Also, I'd sort of be living with pain 6, 7 out of 10. Sometimes it'd go down the legs. It was a very unpleasant time, and it acutely increased my empathy for the patients I was seeing, actually. Because before that, I may have had some sympathy, but I don't believe you can really understand what someone's going through unless you've experienced it yourself. And I had the fortune and misfortune to experience it. And so And I was just finishing my PhD at the time on stress and pain. And as I finished that, I thought, well, I better have a look at low back pain. So I went and looked at all the research, or a lot of the research that I could find on treatments and pathologies and things. And that's when I wrote a book a year later, Fix Your Back, which many of you may have seen. And that's what really piqued my interest. Now, the body is full, with MSK pain, it's really simple. We've got bones and washers, and bones hate pressure. Hence, there's no two bones in the body without a washer between them. And really, my job is to correlate a person in front of me, their symptoms, with a scan and examine as well sometimes. So when about a few months later, the pain wasn't going anywhere, and I did a scan. I had a scan done. And so the left-hand side is myself. Oops, sorry, guys. And what you see there is a markedly narrowed L4-5 disc with modic changes, and the modic changes are at 4 levels, and there's one reasonably normal disc with hydration. And when you look across the other side, you see a relatively normal disc of a person with a similar age. And this was actually around 9 years ago now. Yeah, this happened 9 years ago. So when I saw this, it was a bit devastating actually, because I sort of started wondering that this is the spine of worse than 90% of the patients I treat actually. And it's sort of akin to someone who's closer to 80 or 85, and I was 40 something at the time, 45 maybe. So I didn't really know what to do or expect. And what I have learned is that patients and everyone at large have potential pain generators. And I really like that term, and I use it a lot now. So we all have washers in our bodies that have been damaged in the past, perhaps from sports, falling off a playground. And if you did a scan of everybody, we'll see black discs, some cartilage loss, with most of the population over the age of 30, at least in one part of your body. However, as we know, not everyone has pain. So I like to think of these changes as potential pain generators. Now, the reason why some people may have pain and some people don't is because of pain threshold. So the electricity from your body goes to your brain and sparks electricity in your sensory cortex. So migraine is a condition in which people have a lower pain threshold, because the electricity goes to the brain and it sparks and you get lots of electricity. And that's why people with migraine have 3 times more all pain, MSK pain. They have 6 times more fibromyalgia and 5 times more complex regional pain syndrome in multiple studies. The other thing that happens is stress basically amplifies pain, and that's what I studied in my PhD. So stress attaches to your brain and increases electricity in the sensory cortex. Stress also increases electricity in other parts of your brain, the reticular formation for insomnia, the amygdala for anger, irritability, anxiety, panic attacks. And basically, that's one of the problems with pain and stress. So stress amplifies pain, and pain produces stress chemicals, which amplify both pain and stress. And hence, chronic pain syndromes are similar to chronic stress problems. Insomnia, anxiety, depression is rife. The other thing I've learned is pain has a volume, and pain is not a flat sheet. It actually starts like a golf ball and ends up like a soccer ball. And this volume is in our homunculus in our brain. So, quite often neck pain can give you a headache because it just spreads. Now, this is a really important thing to understand, because the 4 most common sources of lumbosacral pain are the disc, hip, facet, and SI joint. all four of them can give the same pain pattern. They can start like a golf ball and end up like a soccer ball. So your hip can refer to your lumbar spine, and here basically your lumbar spine can refer to your hip. So the pattern of pain is not really always synonymous with the pathology. And people with migraine, because they produce lots of electricity in their brain, they spread pain. So the actual electricity in the homunculus just spreads out. And all of a sudden, you get widespread pain. And so it's often difficult with people with migraine and low pain thresholds because their pain can vary from their site of problems. The other thing that's really important to know is that you don't just have to have one singular source of pain. You could have all four, or you could have three or two, or just one. And then there are other sources as well, but these would account for most of them. So the really important thing in the history is a loading pattern. And this really determines, and I do a lot of telephone consults all around the country and in other countries, and on a phone and with a scan, you can work out probably 95% of people's problems relatively easily, because what we're looking for is a loading pattern. And if it's your disc, bending or lifting may aggravate pain. If it's your hip, it might be running. And, there's certain historical features that will direct you to the source of pain. Then you may get a scan done of some sort to corroborate with your history. The exam is to reproduce pain. You're basically jamming the bones against each other, and if they go ouch, you know that may be a source. And the radiology is a correlation analysis. So you can't just say, oh yeah, all MR scans show lots of problems, so it's meaningless. You may have some sites of damage of your washers that are potential pain generators, but you haven't loaded them. Hence, if you're an office worker, and I was working as a pain specialist when I had my pain, I could go to work, I could stand up in my chair, and I could modify it. Now, if I was a scaffolder, there is very little chance I would make it to work because of the loading that they do. So how do we distinguish? By loading patterns, and I'll get into that in a little. So the Pain Guru app that I've produced has a diagnostic questionnaire in it, and you flick through these screens and you answer them, and it comes up with like the 4 possible diagnoses. Now, sometimes it'll come up with 1, and sometimes it'll come up with 4, because sometimes these things overlap. When you sit, you're putting pressure on your disc and your lumbar spine, but you're also flexing your hip, and sometimes your ball can ride up on your socket. And when you're sitting for a long time, and when you get out, you're stiff. So, sometimes there's an overlap. However, it's quite a good thing for people to understand overall that, and over 50% of people with low back pain and discogenic also have hip pain. So we're probably more dealing with multiple sources of problems in our chronic pain population than singular sources of pain. And a one fit for all is just not going to work, actually. It's definitely not going to work. If you walk with a limp, your relative risk of hip pain is about 14 in studies. So there's certain things in certain directions which will give us a clue. Now, the body positions affecting the spine, for those out there who lean forward in their chair, I implore you to stop. It's 275 kilos through your spine, through your lumbar spine discs. When you sit up straight, it's 50, and that's not a good position to sit in. And with that, Swiss balls, stools of any sort are no good to sit on for the lumbar spine discs, because they put pressure straight through your spine against your chair. Sitting to the back of the chair means that some of the body weight is transferred through the back of the seat, so that's quite good, or it's okay. Reclining is the #1 position to reduce the pressure of our spines, both our neck, thoracic spine, and lower back. And my recommendation to all my patients is to recline when relaxing, reading, and watching television for the rest of their lives, because we do a lot of things that we're bending down and loading our spines, just about cooking and cleaning and many, many things. Hence, if we can take the pressure off our spines for a couple of hours a day, we may in fact be a lot better off in 50, 60 years time. So we're heading for a lot of, well, we have already a lot of problems, and neck pain has overtaken low back pain with the screens and looking down already. I probably see 2 to 1 neck pain nowadays. So I've asked some patients to use their names, and they're fine with it. And I think it makes it a bit more real. So Clinton Pinto's a mate of mine, and he was in his early 50s when this happened. He's a musculoskeletal radiologist, for those of you who don't know him. He's very experienced in lectures around the world. He was doing a yoga pose. This was about in 2018, a week before I saw him. And I did see him as a friend, actually. He felt a twinge in his back, and a week later, he was lying on the ground, pretty much unable to move. And fortunately, he'd just moved back from overseas. He was at his parents', and so he had some support. But I remember going to see him. I was in Wellington that day. I'd fly down there to see my mum, and I flew back, and he rang me and said, look, it's not so good. So I actually took over my inversion table at home to his place. And he was unable to work for 3 to 6 months, and then he went back to work slowly. A lot of leg symptoms and lower back symptoms. It was a pretty difficult time, actually. The scan was done, and as you can see, it shows a large disc prolapse at L5S1. Now, this was pressing on the nerve roots, going down his leg, and a large disc prolapse like this is fairly nasty in that it hurts a lot, and it takes around 6 to 18 months for a reasonable recovery. And if I see this in a scaffolder or a manual labourer, on my watch, they will not be going back to work until they have zero pain, because it's just not going to do that well with pressure. And many of them will actually, I would recommend them to, if they're young, to try and change their careers to something lighter. Because the problem with the disc is that once it's dehydrated, it will narrow over decades, and then your facet joints will rub more, and you'll get spinal stenosis as when you're 80s and 90s. And we see far too much of that. So I borrowed my inversion table. He reclined, stayed off work for a while because he had to sit all day as a radiologist. He did end up getting a standing desk, went back to work slowly, and he's back at work full time now. And he does have a little bit of nerve pain down the leg still. But other than that, he's doing great. And a scan was done about 6 months later, and the disc is totally shrunk, as we can see here. He didn't have a transfemoral steroid injection. He didn't have a discectomy. In fact, I've had one patient have a discectomy in about 15 years now for a disc prolapse. And it's like, I think, as I was saying before, a transfemoral steroid injection can be useful to reduce pain, but often people have their symptoms back in 2, 3, 4 years, sometimes less than that. And although it might be a good analgesia for a short period of time, and maybe a long period of time for some people, it's quite nice to treat the disc at the source of the problem. Courtney, if you have questions, I'm happy to answer them at some point.
We can probably wait to the end, I think. I can consolidate them. Yeah.
Now, this is our own Bruce Errol. He came for left knee pain, actually, and he had some difficulty walking, and there was no pain at rest, and he had a medial meniscal tear, no arthritis, which was the main thing we wanted to exclude for his knee. And his pain resolved, and he was fine. He didn't have surgery or anything. But what I tend to do is have a look at old x-rays and scans that people have online. And this is the great thing about online radiology. And his L5S1 disc is markedly narrowed, as you can see, and there's osteophytes sticking out. And I did advise Bruce about that, and I think he still sits on his chair leaning on his chair, because I think his eyesight for the computer is not so great. Although this is not very painful, and it's not giving him much pain at all, I think it hurts when he stands for a long time only. It is a potential problem, and he's in his 60s. And I think that, what I want to impart is that it's okay now, but if you carry on, get a few more osteophytes, a little bit more disc narrowing, it will become painful. And when it becomes painful, it will probably be painful forever. And then the nerve roots may get some constriction through the foramen. So you may walk bent over for the rest of your life at some point. And that may be 70, 80, 90. We don't know. But it's probably not worth taking the risk. And hence unloading and other things could be helpful. And this highlights the importance that we have potential pain generators, and they're sitting there, and they're also potential risks that most of us would like to mitigate. And now the reason that some people feel pain is that they might be on the migraine spectrum. On the other end of the spectrum, what happens is the pain basically is produced in your body, and it goes to your brain, and it just peters out a little. And I'm like that as well, and so is my whole family. I've had 2 siblings with bone-on-bone hip arthritis presenting with bone-on-bone, and another brother had a neck operation, 3-level, at the age of 50 after a minor accident. So it probably does tend to run in families, and it's probably genetic in some part. But I think it's worth knowing your risks. And fortunately, with Mercy Radiology, who I liaise closely with, I struck a deal with them a few months ago that they'll do the whole spine when I ask for one part of the spine. So if I ask for a low back, I'll get the whole spine in enough detail to give people their risks in their neck. And we've had half a dozen minimum having disc prolapses sticking into their spinal cord in their necks when I've asked for a lumbar spine scan. So it's a little bit like a warrant of fitness, I suppose, for want of a better word. And at some point, just like having your cardiac risk done, this may be a reasonable idea. And Bruce also had a little bit in his neck. And as you can see at this level, he doesn't have some neck pain, but it's pretty narrowed. And there's a few osteophytes. And the spinal cord is quite important in our neck. So this highlights the potential pain generators and potential risks that people do run. And quite often, people can, do things, load the spine or the hip for that matter, run for years, and at some point they get pain. And it's, and it's all, I explain this to patients like the hip, say, if you basically have impingement and the ball hits the socket, it's like you've almost got 1,000,000 clicks and it doesn't hurt. But if you reach 1,000,001, it just starts hurting. And there are a few reasons for that. Probably the formation of new blood vessels, nerves on the bony ends. But it's, and so it comes as a surprise to people. Why does it hurt? I didn't do anything. We're very much a cumulative being in that what we do every day and the postures we hold will create problems maybe in our future. Now, well, we're talking about people I know. This is my mother, and she has a pretty good looking back. It's better than mine. The disc heights are certainly better if you looked at the two scans. And she's a little bit older than me, but she was experiencing a lot of pain actually, and a lot of nerve pain down the leg. And in fact, she's about 82 now. About a couple of years ago, she had a foraminal decompression, and it was reasonably successful, although she still has some symptoms. And this scan shows us a facet joint, and the right facet joint is markedly hypertrophied compared to the left, right? And so these are the sort of things that we can see on the scan that say to me that this is and if, you know, she had right-sided pain when she bent and twisted, and that's probably the facet joint basically hitting. And it's just like a joint. Twisting, bending will create pressure on that joint. And so she may have some disc pain, you know, at these levels, because there's a little bit of narrowing dehydration, but she's very likely also to have facet joint symptoms. And if you've got a slightly dehydrated narrow disc, as you can imagine, your vertebrae are slightly closer and your facet joints are slightly closer. So each time you bend and twist, they'll knock. And over decades, they'll create burrs and spurs or hypertrophy. And that can interfere with the foraminal space. And sometimes, if we're not sure what's going on, someone's got good discs and you think, oh, we might get a CT spec scan. I reserve this for people I've been treating for 6 odd months who don't improve, and it sort of can highlight this type of thing, which can be relatively useful in that you could target a CT-guided injection here. There's also radiofrequency, perhaps, which may be helpful. But, you know, quite often people do have disc and facet joint pain, but at least the person knows what's wrong, which can be helpful for people. Now, this was a really interesting case. Someone who's around 30, and he came to me in a wheelchair. And I don't know, but I have a feeling probably the only person, or maybe 2 people in 20 years have come to me in a wheelchair for back pain. And this was the only person that's come with acute back pain, severe back pain, you know, 8, 9, 10 out of 10. And as he came in, I rang the radiologist and got a scan immediately. He actually went straight to the scanner and came back. And it was pretty good. It was perfect. That is pretty much the same as the day you're born, really. And, you know, the discs are hydrated. They've got good height. There's nothing untoward there. So I got him to stand up, and I got him to stand on one leg, and then I got him to stand on the other leg. And when he stood on one leg, his pain shot through the roof. In fact, he couldn't. And when he stand on the other leg, he could stand there forever. It didn't increase pain. And we got another scan done, and he had acute sacroiliitis. And, you know, the edema around the sacroiliac joint. And this sort of taught me that, you know, the sacroiliac joints are a load-bearing structure, and they should hurt more on standing and load-bearing rather than, you know, probably more on standing, walking than sitting. And that's one of the patterns for sacroiliac joint pain that is important. It's diagnosed far too often by practitioners who have their eyes in their hands. And I'm privileged to be able to look at scans. You know, it's for 20 years I've been able to look at scans and correlate with patients and try and do some learning about this. And if you're sort of allied health grew up in the 1900s, basically with hands and eyes. And so that, you know, compulsion to look inside the body has not always been there. And it's something that probably needs, I think, education really to go for the jugular find out what's wrong and then manage someone. That's truly the way I believe it should be done. And this patient has a very flat hip as well as some arthritis, but that oval head neck junction is a European hip, and I sometimes cheekily call it a white person's hip. And the reason I say that is because Europeans have been sitting in chairs for 1,000 years, they no longer need a round hip that fits in the socket. Whereas Asians have been squatting until probably recent times, and so their hips are rounder, and hence Asian people have less hip problems, but they still have hip problems. And they sometimes have deep sockets, and with deep sockets, you knock the edge. So this is why, and approximately 50% of the population have a shape of the hip that may create knocking. And that's why it's very prevalent, and it sort of refers to the back as well. And so the paradigm of hip back pain is quite strong. And the easy way to tell between disc and hip is if patients have a pain score of 5 to start with, they go for an hour, half an hour's walk, and their pain increases to 8 or 9, it's not likely to be the disc creating that pain on walking. It's probably more likely to be the hip. So in the app, we've got it's like a video library, actually, is probably the best way to describe it. And the understanding pain goes into how we experience pain, referred pain, the role of migraine, stress, painkillers, and pain modifying medicines. Painkillers work in your brain and sometimes spinal cord. They don't really tend to work in your structures in the doses we use them. Even anti-inflammatories, pretty much all medicines, I would say that's a safe thing to say, except maybe injectables like steroids, obviously, but analgesics work in the brain. We're individuals, and we have different receptors in our brains, which are the target of these medications. Hence, some people will respond to one medicine and some people to another. So it's very person specific. And sometimes we need to relay that to the patients and say, hey, look, here's a painkiller, try it. If it doesn't work, get back to me. And sometimes I'll actually prescribe 2 or 3 of them and say, hey, look, try that first, then try that, then try that. And then you might want to try them all together if none of them work, because if they all work on different receptors, they're likely to have an increased effect, and that's okay too. So you go down the screen, it comes up with you push it, and then you get the next screen, how do we experience pain, which is the first of the previous screen, and there's a video. So I've tried to make it easy, actually. It's a bit like my books, but in a video format to make it easy for patients. The app is a one-off cost. It's taken a couple of years to make. We've had it made in India with some of a liaison person in New Zealand. All the content like videos and things we've done in Auckland. But I've been pretty happy with it, actually, and we're really just releasing it because we've had some modifications, but it's at a reasonable step. The other screens will go into disc pain, hip pain, sacroiliac joint pain, facet joint pain, and there's a whole lot of things, and each of them has a sub-library, and each of them has a sub-library. So it's a lot of flow charts and a lot of time. But as I said, it's been really, it's been well received, actually. We've had a lot of people feedback from around the world and places, Sweden and Israel and obviously New Zealand as well. So it seems to be universal, and it's probably going to achieve the aim of trying to get the education out there globally, which is my aim. And when you manage MSK pain, you want to avoid loading activities. And for myself, I gave up cycling, sold my road cycle. I gave up kayaking, sold my 2 kayaks, because it just wasn't going to end well. If I was going to go for another, 30, 40 years or whatever, it was going to hurt. And I needed to preserve my discs, and I didn't want any facet joint hypertrophy, so I don't walk bent over when I'm older. So a lot of the loading, I used to do woodwork, carpentry, concreting. I used to love, just doing anything physical, but I now don't do lawns, don't do gardens. I lie on my bed and read or a lazy boy. And pretty much the only time I'll sit upright is to socialize, eat, and sometimes at work. Otherwise, I'm usually reclining. If you've got a hip problem, don't run. And if you've got a knee problem, don't run. Because if you have structures, that repeated pounding over decades is only going to basically wear it out. And you need to modify activities. Activity modification is the #1 way to manage musculoskeletal pain. I've probably had over 500 elderly people buy a lazy boy over the past 5 years. And probably 3/4 of them report markedly reduced pain because they're now reclining when they watch TV, read and relax. And it can be that simple sometimes. Traction, there are several trials showing an average of 60-odd% reductions in pain. This is double any other treatment in the world for low back pain. Let's look at core strength. Shows around 30% reduction in pain, but ultrasound guided core strength is no better than just doing any exercise you want. So exercise is good for you generally, that doesn't hurt, but core strength training has proven not to help. And it's been our #1 paradigm. The factors that determine pain are your disc, how narrow and how protruding it is, the pressure you place on it, and your pain threshold, courtesy of your migraine status, and that's a spectrum, and stress chemicals in your brain. And there might be other things too, but that's probably the way to look at it, rather than, because, and the other thing is, I'd be running an obesity clinic, really, if back pain was related to core strength, and I don't. 99% of the people in my clinic are thin, athletic. We do not see many obese patients at all. Weirdly, we just don't see them. So in any sort of traction will work. There's hanging by a door, the traction, inversion. Inversion traction, the only real contraindication is eye pressure, vitreous pressure, glaucoma. That's the only contraindication, and someone's coordination to get on it. So there's other ways to do traction, and they're all outlined in the app as well. As I said, painkillers work in the brain, trial and error, go through them all. I would not forget medicinal cannabis. It's very, very good for sleep. It has no tolerance. I've had people on it for 2 years on exactly the same dose. In my PhD, I went through receptors and how they work, and it's got a very novel receptor action, which doesn't lead to tolerance. And so it will be, in my opinion, the #1 analgesic for chronic pain within 5 years globally. But you still won't make money on the shares because there's a glut of it. Canada have more than they can use up, and probably more than the world can use up. So be careful with those cannabis shares. For MSK pain and all pain, we want to reduce sympathetic tone. We basically want to reduce the stress chemicals floating around in the brain if we can, so that there's electricity in the sensory cortex. And that's exercise, sauna, yoga, sauna, spa, baths, 20 minutes, yoga, meditation, slow breathing, Tai Chi. Now, my favorite, because it's probably the cheapest, is the meditation, slow breathing. I actually now, when people live rurally or they can't afford sauna, spa, bath membership, I get them to lie in an electric blanket that's on full during the day, put their hands on their tummy, take a deep breath in for 5 seconds and out for 5. You close your eyes. By breathing in, you stretch your lungs, you increase parasympathetic tone. When you breathe out slowly, you reduce sympathetic tone. It's the perfect exercise. It can't hurt your back. It doesn't cost a few cents each time. You know, and there are very few people that have a lot of pain lying down, generally speaking. So I found this really useful for people who can't join the local gym, go to the sauna, spa, bath, and do exercise in the swimming pool. These have all been proven in randomized controlled trials to reduce sympathetic tone and improve parasympathetic tone. And many of them have actually been proven to improve insomnia, anxiety, depression as well. Not all of them have been studied for that, but the flavor is there. Now, how can general practice manage low back pain? I believe general practice can manage low back pain the best of anybody, personally. Disc pain is the most common source of pain. If people in the audience have the ability to place an inversion machine in their clinics, I would recommend it, because the studies show 3 times a week for 6 weeks reduces pain by about 60% for a disc prolapse. And if you do it for 10, 20 weeks, it'll be even more. And if people don't have room at home, they can come to the clinic. And if funding's an issue, it could spark a nurse consultation who could put them on the machine. You know, there's many ways to skin this one. People can pay some money towards it. And, you know, and I think it's probably a really interesting way for general practice to manage low back pain. And the machines are, I can get them wholesale. So, you know, if any of you would like a machine for your practice, email me, or our website's gireshkanji.com, and the email's info@gireshkanji.com. So you can email me through the website, say, hey, look, I'm from this practice. They're $600-700 wholesale, $1,300 retail. For patients, I only recommend the $100 or $200 machines on Trade Me, because for most patients who are 5'8", or, you know, if they're not 6'5" and 150 kilos, you don't need to buy an expensive machine. But I think for practices, it's probably nice to buy a reasonably good machine. It's only 30 degrees to 40 degrees. You don't have to be more than this. And generally speaking, if people were coming into the clinic, you'd have them 2 minutes back, 2 minutes up, 2 minutes back, and you do about 3 or 4 times, you know, even 3 minutes, 2 minutes, it doesn't matter, that sort of thing. And so you might have them on there for 10 minutes or so. It is a self-treatment, but not everyone can afford a machine. Not everyone has the room for a machine. And if we had a network of clinics throughout New Zealand who decided to get the machines, it would be really, really amazing, actually. And, you know, we may even be able to put it on our app, and a map of all the places, all the clinics in New Zealand with an inversion table, so people can just go along and think, okay, I'm going to go and try it there. So I think that's probably a reasonably, and, you know, the other thing there is become familiar with MRI scans. Not everyone has the interest, and you're busy, but if you have the interest, I'd be more than willing to run a webinar on MRI scans and reading them for general practice. Courtney, I mean, that's a possibility. If there is enough interest, email the Goodfellow Unit, and I can do that on the webinar. You know, and that maybe it will help. MRI scans are way easier to read than X-rays. I mean, X-rays, ooh, they scared me, but MRI scans, honestly, are the most easy things to read. They're black and white, and, you know, they're shades of grey, but most people can become familiar with obvious things and even subtle things, I would suspect, within 6 to 12 weeks by looking at them. And IntelliView is brilliant, although there are 6-7 clinics in Auckland, which make it more difficult than Wellington, where there's only 1 clinic. Postural advice, very simple. Unload it for the spine, especially if you've got a lot of pain. And, you know, we're likely to help 50% of people with lumbosacral pain, probably 75% improvements across the board by taking just this approach. And we're likely to reduce surgery by 75%. The inversion table has been proven to reduce discectomy rates by 75% in a randomized controlled trial. 2 groups waiting discectomies in England. 1 group went to inversion and physio. One group just did physio. The inversion plus physio group, I think it was 2 out of 10 went to surgery. The physio only group, 8 went to surgery. So it's pretty stunning. And the transfemoral steroid injections, yeah, as I said, I probably do 1 or 2 a year. I don't do them myself anymore because it's just not worth it in terms of, I just don't do them enough to warrant or shrink their discs and their nerve pain subsides. Okay, questions?
All right. Thank you, Giresh, for that interesting overview and discussion. So a few questions in. Someone just wanted to clarify what you meant by reclining. How much do they kind of need to be back? Does it have to be lazy boy?
Sure. Look, it doesn't matter too much, but if you sit to the back of say that's the back of the chair and that's your spine. If you sit like that, it's 250 kilos if you're leaning forward. If you sit up, it's 50, say, just for argument's sake. And if you sit back, probably 30. And I think somewhere comfortable, right? And like if you're watching TV, ideally put it on the wall. If you're reading, you sort of just go like this. So 40, any degree is fine. And I had one person today, and he reclines right back, and it helps him a lot because he's got quite a crappy spine. So it depends a bit. But and even in my office, I have a gamer chair which comes up to my neck, and that is the best chair for people with spinal pain. And if you have spinal pain as a general practitioner or doctor or nurse out there, a gamer chair means that when your head is against the neck rest or headrest, you're in the right position. Because with the head, 5 kilos straight ahead and 50 looking down. So reclining is excellent for neck, back, and thoracic spine pain. And sometimes in my practice, I'll recline back and I've got a big screen. I'll just read and do bits and pieces on it while I'm in my gamer chair reclining.
Interesting. In terms of the inversion, how many minutes per session on the inversion table?
Okay, so as I said, 30 to 40 degrees is fine. And there's a study that compared 30 and 60 degrees and found no difference. And you can be 30 degrees for like 10 minutes, and that'll equal 60 degrees for 5 minutes. So what I say to people is 3 to 5 minutes at 30 to 40 degrees once or twice a day if they've got one at home. In the clinic, if they come in, I would probably do 3 minutes at 30 degrees, get them up again, then for 2 minutes, 3 minutes, 2 minutes, and another 3 minutes, because they've come from home, and you might as well give them the Rolls Royce. And 3 or 4 times a week is enough.
Can inversion tables help with, we've got a couple of questions, facet joint pain and chronic pain in the buttocks and leg area? It
won't help. I mean, it will help and it won't help. If it's separating the disc, you might separate the facet joints a little bit. For facet joints, I actually get people to lie on a foam roller on their abdomen, right? So if they've got a lordosis, if it's a big lordosis, their facet joints are closer together. So I get them to lie on a foam roller across here on their tummy, and that will reduce the lordosis and separate the facet joints. And I've been doing that for about 6 to 10 months. It's been brilliant. I've had a dozen people go from daily pain to being pain-free almost doing that. Not everyone, but it helped my mother even. And she's got quite a big joint, and she's much better in that right side with the sharp pain just by getting a foam roller, putting across her belly button and lying on her front. And she just does it on her bed actually, but you can do it on the carpet. So that's probably better for facet joint pain, as well as avoiding twisting, bending activities. That includes gardening and things, because when you bend down, when you bend up again, the facet joint touches. And when you go like this and twist, it's touching, because it's sort of one of the reasons you can't spin right around.
Okay. In terms of the canvas, is that something you recommend kind of as a first line, and is it more for sleep rather than pain?
In terms of
the cannabinoid activity?
Look, I think it's most brilliant for sleep and pain, actually, for sleep. I really do. And I think it's because it does reduce pain, but it sedates you. And during the day, I've got about 75 people using it at the moment over the last 2 years. And I'm about to do I'd like to do a audit on that, because we don't have a lot of studies for musculoskeletal pain, and many of these are neuropathic pain as well. So they're what I call end stage pain, this palliative care to keep them comfortable. Some people find it awesome during the day, but when people get high, they don't like it and they actually just stop it. So most people can tolerate it at night very well. Probably only maybe a quarter to a third would use it during the day. And I suspect most people will use it at night. But it's a trial and error. Yeah.
A couple of questions about the Pain Guru app. One is about kind of any costs associated with it.
Yep. So it's free to download, and the Understanding Pain 8 videos are free. You can also go through the diagnostic loop for free. Once you get there and it says, oh, these are the possible sources of pain, it's I believe it's about $3.99 US, is something like that. Yeah, so there is a cost. I've sort of talked about this, and what we're going to do is, as we roll it out, if we find that, out of 100 people with low back pain, only 5 will click the buy button, then I just may make it free. I'll see. There is a reasonable amount of cost up front for the app, just in terms of the software engineers, but there's also an ongoing cost for maintenance. And I've got about 6 other apps on the make, which I'm sort of starting to look at doing. But I think mostly it is for education. And if we find it's a barrier, and it's not always a monetary barrier, but a psychological barrier that, I don't trust this, and so we're looking at that space, and we will look at it. So maybe might get a sponsor, and that may be another way to go. Get one sponsor, and not have to charge for it, because I do want the information out there as a priority.
Okay. In terms of imaging the spine, I think a few GPs have found that there's a few findings that actually have absolutely nothing to do with their pain, and patients tend to kind of fixate on that. And how do you manage that dynamic?
I don't think I think as I said, it's correlation analysis, right? And if someone's got a low back with 2 or 3 discs that are dark and dehydrated but not narrowed, and they've got low back pain when they bend and lift, you could probably reasonably sure that those discs are causing pain, because it's consistent with the loading pattern of their pain, right? So I think, and I think I don't think, and sometimes, as I said, when I do a whole spine, I'll see changes in the neck and people are not getting pain from them. So it's a potential pain generator. So I don't really know how to answer that, because, like pretty much the scans I do, they show things. And sometimes they'll show facet joint hypertrophy, but, they don't have facet joint pain. When they twist and bend, there's no pain at all. So you're right, a lot of the things can be abnormal without pain, but I suppose we need to focus on the correlation. And that's probably the key aspect. And the other findings are more, potential pain generators, which people probably may want to reduce loading on for the next few decades. So, yeah.
I think what I've gleaned as well is that really the most helpful information is going to be from your history, not too much from exam, a little bit from imaging to kind of correlate with the history.
No, I think the imaging it's objective, verifiable data for me, right? And that to me is really important. And to all the patients I see, I've got a big screen, television screen at work. I put it up, they look at it, they think, oh, great, I now have an idea a feedback loop of what might be wrong with me. And then I'm going to do some simple things like invert, get a recliner chair. And then in 6 months' time or 6 weeks' time, I do a telephone consult, or they come in and they go, oh yeah, look, that really worked. So if I was doing fusion operations, I'd have to be a lot more sure. And I wouldn't want to say, oh, that's the source of your pain, because, my solution is a fusion operation. And so for me, saying that might be a source of your pain and this is how we're going to solve it doesn't have quite the same repercussions as a surgeon.
Is there any role for, say, a DEXA scan for a postmenopausal woman with lower back pain?
And I've seen a couple of people over the 10 years for a DEXA scan, and I saw a lady today who had a disc prolapse into the vertebrae rather than out through the end. So, what we often call a Schurman's type node, but it's actually a disc prolapse that goes into the vertebral end plate. And it can probably only do that. And then we saw another patient recently who had a compression fracture in their lower back, and it's very odd. And so for those patients, I would send them for a DEXA scan, bone density scan, to make sure they're not very osteoporotic. But in terms of pain, there's not really the correlation between bone density and pain, really, right? I don't think that's a thing. Yeah.
What do you think of PRP in the treatment of back pain?
PRP?
I think they mean platelet-rich plasma.
Yeah, that's, I know. Yeah, no, sorry, I just didn't hear. It's probably not dissimilar to steroid injections, epidurals. And, the use could be when you're in severe pain. You might want someone to stick a needle in your back, and you may not. And generally speaking, if they do, it could maybe relieve a very, very severe pain, 10 out of 10, for 6 months, and sometimes 3 months, and sometimes 2 years, and sometimes for a week, right? So it's fine for desperate people. For my practice, I trained in Australia twice, went to Newcastle for 6 weeks, learned to do transfemoral steroids, radiofrequency, and I used to do them, and I could do 500 a year easily, and you get paid $1,000. And if it's the way you practice, it's sort of a self-fulfilling loop. And then I don't do any, and many patients get better, and maybe some patients could get better if I did more injections. It's possible. I don't know, because it's just not the style I practice. My interest is in pain for the rest of your life, and if you want an injection straight up as a first course, there are plenty of people you can go and see. And I don't mind seeing you and sending you if people want something. I'll just say, okay, well, you're the patient. If that's what you want, that's fine. But most patients with counseling and knowledge think, okay, well, look, let's try this first. If we don't get anywhere, maybe 3 or 4 months down the track, we can put a needle in your spine. Now, the risk of vertebral compression fractures increases 22% with an epidural steroid in studies. So, there are risks associated with everything we do. And, there's a few people that get, the risks aren't great on a percentage scale. But it's just not my style of practice, that's all.
Is there any treatments or anything available to stop or reverse the dehydration of intervertebral discs?
It's irrelevant. It's like our kidneys. We've got 2 kidneys. We need about half a kidney, I'm suspecting. We've got a big liver. We probably, if we lost 3/4 of it, we'd probably still function. It's the same with your discs. So I've had 0 pain for about 8 years now, right? So when I did my scan for the next 2 years, I had some pain. Then I got an inversion table when I read the studies that it was, looked like the bee's knees, got a recliner chair, and the pain just went away over 6 months or so. And I've never had a return of that pain. So yeah, that's sort of, sorry, ask the question again, Courtney.
It was, let me find it. Anything to stop or
Oh, yeah.
reverse
So,
the dehydration?
yep. So I've got massive dehydration and narrowing in my discs, and I don't get any pain. So we don't need to we can't rehydrate the discs at all. They're actually glycosaminoglycans, multiple filaments, really tiny, and they're hydrophilic. So what happens during the day when you're loading is you squash it, the water goes into the bones, and you get about 2.5 centimeters shorter during the day. And when you lie down at night, the water basically comes back into the disc and stays there because of these hydrophilic filaments. When you have a disc prolapse, the gel is exposed to the outside world and it doesn't like it. It breaks down. And so it takes 2 years on serial scans for a disc prolapse, for the disc to go from hydration prolapsed to dehydrated. And I've got serial scans for lots of people over decades. And I'm writing a textbook, sort of a book regarding what happens over time. So you don't need hydrated discs at all. Yeah. We've got plenty of reserve, is probably the word.
There's someone who's got kind of a case here. They've got a 43-year-old patient who's had chronic pain for about 5 years. Their MRI and X-ray results show just degeneration of the discs of L5 and S1. Where else should they be looking for the source of the pain?
So that would be a perfect case. So the other thing about inversion traction and posture is you can do it for 6 months. If it's their discs, their pain will completely subside. That's pretty much it. Sometimes I'll do it as a test. I say, hey, look, we're not quite sure. We know you've got some disc pain. Let's do this and see how you are in 6 months or 3 months, right? And then if their pain is still painful and they come in, then I'm always looking for something else. So with that patient, if they had pain that worsened from say 5 to 7, 8 when they walk 30 minutes, I'd be looking at the hips, pretty much. Yeah, I think that'd be the simple answer to that. But the dehydrated discs could be the source of their pain. In saying that.
Someone has asked, just you mentioned about SPECT CT and usually wait about 6 months before you order one of those. Why is that?
Order a
SPECT CT?
Oh, because quite often we'll sort it out by then. Right. So quite often they've got a disc prolapse, we get an inversion table, recliner chairs, and many, like a large percentage of those people will just get better. Mm-hmm. And so we've already got a diagnosis. Now, should someone, carry on with pain over 3 to 6 months while we're trying different treatments, then we might think, okay, well, what's going on here? We might need a bit more of a clue as to where the bone is rubbing the most. And then I might say, okay, let's get a CT SPECT scan. And I did this recently, and the person's sacroiliac joint, hip, facet joint, and intervertebral disc region lighted up. Oh. Yeah, so and so it was like, okay, well, here we are. You've actually got a few things going on here, and that's why none of these you're not getting totally better. So it's just because most get better.
We've got time for a couple more. So what non-loading exercise do you recommend?
It's whatever doesn't hurt. So I've got a disc problem. So there's 3 things that I would recommend that you never do, okay? And I would recommend these relayed to your patients. Deadlifts, squats, and lunges. Mm-hmm. I'll explain why. With the deadlifts, when you're bending over, that's 100 kilos or 200 almost. And the bar at the bottom, if it's 20 kilos, can impart probably 100, 200 kilos on your lumbosacral disc as well. So you're sort of getting up to half a ton just about, a lot of force. And all you're exercising is your shoulder muscles. It's bizarre. And I've seen too many people come with disc prolapses and back pain from deadlifts. Squats as well load your spine, but they only work your quad muscles really. And and so you can do that with other machines. Lunges will kill your hips because they will basically knock it like this. So those 3 exercises are very popular, but I just wouldn't recommend them in a million years if you want to avoid pain in the longer term. I go to the gym most days, 4 or 5 days a week. I'll do bench press because you're lying down. I can do chin-ups and bar exercises. So pressure on your ass is pressure on your spine. That's quite a good thing. So I won't get on the exercise cycle for half an hour anymore. I might go for 5 minutes. I won't do the rowing machine at the gym, but I'll do some of the machines because you're only sitting for a few minutes at a time doing 3 sets of 8. And yeah, so, sitting for long, and I don't do heavy weight standing or sitting either because, you're often going like this, and that's going to twist and load your spine. So, and probably the simplest thing I give people who can't do anything is walk up and down the water with water to waist height, then jump in the spa or sauna at the gym pool, because that reduces sympathetic tone, and that's quite a good combo. And that's pretty much what I do 4 or 5 days a week, probably, and for a total of 30 minutes all told.
Possibly related, any thoughts on support belts?
Yeah, support belts help. However, they can give you hernias because, if you wear them all the time, they take away your muscle sort of action. And so I've seen probably half a dozen to a dozen patients who have had hernias from support belts. That's not many in the time. There might be more out there that I don't know of. I think if you had some back pain and you want to do half an hour gardening or some activities now and then, putting one on to use for that period of time is fine. That's probably a reasonable use.
And I think we'll finish up on this one. Any thoughts on stem cell treatment?
Yeah. I'm not allowed to say that on live. It's there is nothing at the moment that we have injectable that will help you long term ever, any joint. And that's the truth. There is just nothing. So, we can inject a steroid or PRP or stem cell, but if you just keep going to run on your knee or hip or lumbar spine and keep loading it, it's never going to work for any length of time. And, if you're after relief for 6 weeks, maybe 6 months, that's fine. Stem cells do not regenerate the disc whatsoever, or cartilage for that matter. Cartilage is an inert substance. It has no blood supply. It would be more akin to fiberglass, and you just can't restore it. And the same thing with the disc. It's fairly avascular. It doesn't even have many nerves. Even probably the pain generator is probably more in the bones, I suspect, than actually the disc. Except the outer third has a few nerves, very scattered. So we have no options except the very, very crude options of fusion and disc replacement, where we're replacing a water-filled washer with plastic. Yeah.
All right. Excellent. All right. Well, that's probably all we've got time for. So thank you so much for joining us tonight. Just a reminder to viewers that this will be online on the Goodfellow website from tomorrow, along with a list of any relevant resources. Thank you very much, Giresh, for your time, and have a lovely night, everyone.
Thank you, Courtney. Cheers.